Next, we're going to talk about the risks and benefits. So maybe 10, 15 years ago or so, hormone therapy was extremely controversial. And this was a result of studies like the Women's Health Initiative that came out with warnings about the risks of hormone therapy and what could happen if you were on hormone therapy. So the hormone therapy risks should be discussed with every patient. Every time the patient comes in, they should be reassessed that they still have this indication for therapy, either moderate to severe vasomotor symptoms plus or minus urogenital symptoms. And again, when we're talking about hormone therapy and the risks associated with them, we're talking about the oral therapies or the therapies like one of the rings or the other oral therapies, either the combined equine estrogens or the 17-beta estradiol, any of those oral options that are systemically absorbed are the ones that we're talking about in terms of risks. For vaginal products, they are usually local therapy. So these risks don't really apply to those vaginal products. So every time evaluation for an indication, again, every time evaluated for contraindications. And the popping up of new contraindications at each visit should be assessed. So patients should be offered a discussion with the risks and benefits, and then the results of the Women's Health Initiative or the Million Women study, which is another study that looked at a similar thing, and the concerns that they raise should be discussed with the patient. So the Women's Health Initiative was originally looking at a common cause of death and disability and causes of poor quality of life in women. And out of this large study that had multiple different study arms, there were two arms that were looking at hormone replacement therapy. There are two major randomized controlled trials. They're really large, and 90% of the women that were included in these studies were over the age of 55. So not applicable to every single patient that we might be seeing. So if the average age of menopause onset is 51 years old, there's probably a large portion of patients that are treated with hormone therapy that this study might not be very applicable to because they might have less risk because they're a younger age. The first part of the study was an estrogen plus progestin, and the second part that you can see here was just estrogen alone versus placebo. So the combination versus placebo or estrogen alone. And these were the outcomes that they found. So there was an increased risk of heart attack, stroke, blood clots, and breast cancer with hormone therapy, but there was a decreased risk of colorectal cancer and fractures. With the estrogen alone, they found similar things, no difference in heart attack, but increased risk of stroke and blood clots, no difference in risk of breast cancer, but a decreased risk of hip fractures. These studies were stopped early as a result of the cardiovascular complications, so the coronary heart disease, stroke, and thrombotic events. So they stopped the studies early because there was such an increased risk in these. The Million Women study, which was another study similar to the Women's Health Initiative, I didn't put in here because it's a less commonly cited study, but basically it followed 1 million women in the United Kingdom, and they were at least over the age of 50. What they found in that study was there was an increased risk of ovarian cancer, a decreased risk of colon and GI cancers, an increased risk of breast cancer, an increased risk of thrombotic events again, an increased risk of gallbladder disease, and an increased risk of endometrial cancer. So one of the themes that you should be seeing as a result of this is that these are really all of our absolute contraindications. So if a patient already has one of these things, you don't want to put them on hormone therapy because it will significantly increase their risk. So for vasomotor symptoms, 80% of women that have menopause or are in a postmenopausal state will experience vasomotor symptoms. So not every patient, but a large majority. Oral hormone therapy is recommended for reduction of those symptoms. Duration is typically 5 years, but it's not uncommon to see patients out to 10 years or sometimes even longer. Goals should be cessation within 5 years, but it's really an individualized patient decision again. Most women stop within a couple years of initiating, so we're not really seeing a ton of patients that are on this for 15 years. And basically what we're trying to do is do anything we can to decrease risk of those side effects that we're seeing in the Million Women study and the Women's Health Initiative. Half of women that are postmenopausal will experience symptoms of urogenital atrophy and urogenital symptoms associated with estrogen deficiency, and this is a result of the estrogen receptors that are on the vaginal canal. Most women will require some sort of intravaginal estrogen preparation, and the decision of which to use is really individualized per patient. Some would prefer a cream, some would rather have an intravaginal tablet, some would rather have a ring. So it's really individualized as to which one they choose. Because this is just local therapy and it's really just for the urogenital symptoms, if the estrogen is only given vaginally, it does not usually require a progestin because there's not enough systemic absorption in order to cause endometrial hyperplasia. So you wouldn't need to add a progestin for that unopposed estrogen. So for patient counseling, same things. You talk about the women's health initiatives with patients and the risks and benefits. What can we do to mitigate the risk using the lowest effective dose, limiting therapy to less than 5 years if we can, and then really choosing the appropriate patient and reassessing for indications and contraindications. This treatment algorithm is very helpful. So when you're thinking about a menopause patient, think about what symptoms they're complaining of. So do they say they just have hot flashes? Do they say they have hot flashes plus, painful intercourse? Do they only have urogenital symptoms alone? Another name for vulvovaginal symptoms. So if they don't have symptoms, then you would just, continuously assess them for cardiovascular and osteoporotic risk associated with low estrogen. If they do have symptoms, then you would go down any of these pathways, the one that's most appropriate. So starting with OTC products and then moving to prescription. For this middle column, usually we would give an oral therapy. And then for this column as well, we give an oral therapy. So anytime that they have vasomotor symptoms, they need an oral therapy. They won't be able to get by with vaginal therapy alone to treat the vasomotor symptoms. So systemic estrogen, unless they have a contraindication to hormone therapy. We have a couple other options that I'll go through for things that will be helpful if they have a contraindication to hormone therapy. There are some non-hormonal options, but we'll talk about those later. Okay, so we'll go through these two cases in class. There are some additional therapies for treatment of menopause. Androgens are used sometimes, not very commonly. The section I want to kind of spend a little time on are selective estrogen receptor modulators. So you might have learned in osteoporosis already about raloxifene or Evista. And then there are two others that are indicated for menopausal type symptoms, ospemifene, which is indicated for urogenital symptom of dyspareunia, and then Duavie, which is a combined estrogen product with a SERM. So when we think about SERMs, we have to think about how each of the different selective estrogen receptor modulators will act on different estrogen receptors in different ways. Some will produce agonist effects and some will produce antagonist effects. So our objective is to produce the benefits of the SERM while minimizing the harms of the SERM. So usually we want to cause improvements in bone density, improvements in vaginal tissue, while minimizing things like agonism on the breast, which could cause breast cancer, or action on coagulation factors or lipids. We wouldn't want to increase lipids or increase risk of VTE. So I included this chart and I kind of piecemealed it together because there are some SERMs that aren't really ones we've learned about, but This would be the ideal SERM. So something that does not have um, an increased risk of breast cancer, something that improves bone density, improves the lipid panel, that doesn't increase the risk of thrombotic events, and that doesn't cause endometrial hyperplasia, would improve urogenital symptoms by acting on the vaginal canal, would improve hot flashes, and then may or may not have an effect on gonadotropin. It's less important. So we learned about the SERM clomiphene before. For that one, we know that it has an effect on gonadotropins, and some of the other effects are kind of unknown. For these other SERMs that are more for menopause type symptoms, so bazidoxifene, ospemifene, and raloxifene, they have different effects on different receptors in different tissue, and that relates to their indication. So raloxifene really works well for improving bone mineral density. It does not alleviate hot flash symptoms and often will actually worsen hot flash symptoms for patients. So if they're just using that SERM for prevention of osteoporosis as a result of menopause and not for vasomotor symptoms, it would be an indication. But if the patient also has vasomotor symptoms, this might not be the best option. Ospemifene is really only for the urogenital symptoms, and then Duo-V is for moderate to severe symptoms that are vasomotor symptoms, and it's really for patients that have a uterus. So this is an option instead of estrogen plus progestin, because the bazidoxifene has effects on the endometrium that prevents endometrial hyperplasia. So you can give the estrogen with this instead of a progestin. Other types of therapies that we have are SSRIs, SNRIs. These can be treated for vasomotor symptoms. Paroxetine has a newly approved FDA product within the last couple years called Brisdel that's specifically for vasomotor symptoms, and this is a good option for patients that have a contraindication for hormone therapy. SNRIs might also be helpful. Another drug called prasterone is FDA approved for dyspareunia. It was approved, I think, last year. Clonidine and gabapentin provide some relief of vasomotor symptoms. Both of these have gone up before the FDA panel to be approved, I think gabapentin more recently, and they have not actually approved an indication for vasomotor symptoms for these, but they are sometimes used if some of the other non-hormonal options have not worked. And then the last section I'll just touch on briefly because there's a third case about this, are bioidentical hormones. So these are preparations that provide a unique mix of either estrogen types, sometimes adding progestin, sometimes adding androgens or other corticosteroids. A lot of times these are compounded in pharmacies and specifically tailored for as an individualized regimen for women. It's important to remember that there are no studies done to establish the lowest effective dose for these or determining, how much progestin is needed for endometrial protection. A lot of times they're given either transdermally or buccally, so there's not a lot of evidence about that. And then major organizations do not support these compounded bioidentical hormones. Separately, there was just in October 2018 a new FDA-approved bioidentical hormone, and this is not like a different compounded one. This is a specific amount of estrogen and progestin that is a bioidentical hormone. So Bijuva was the one that was just approved, but it's different than those other compounded bioidentical hormones.